formation and hemostasis. If you remember, hemostasis is the process by which you stop the blood loss. And if you remember, we have 3 steps in order for us to stop bleeding. Whenever I have an injury in a blood vessel, if you remember, the very first thing that happens is a constriction of this vessel, because this is my vascular spasm. The second thing that takes place in an injured vessel, if you remember, the lining of the blood vessels is the endothelium, which is one layer of flat cells. Whenever I have an injury to the blood vessel, there will be exposure to the collagen fibers located underneath it. And this what stimulates fragments of cells circulating normally in the bloodstream to get attached to the collagen fibers and will start to become activated, releasing chemicals, their chemical contents, to the outside in the bloodstream to recruit more of those platelets until I fill the injured site with platelets. The plug I form with platelets is what I call the platelet plug. And this is the second step in hemostasis. First step is vascular spasm. Second step is the platelet plug formation. The third step is the coagulation. And remember, in the coagulation process, what I'm intending to do is to fill this injured site with a thick fibrous mesh that is going to be stable, much more stable than the platelet plug, and will allow me to repair my injured vessel. If you remember, we did study 2 pathways for the coagulation. We have the intrinsic pathway and the extrinsic pathway. If you remember what I mean by intrinsic and extrinsic pathways, intrinsic, I'm starting from inside the blood vessels. So the very first thing that initiates the intrinsic pathway would be the platelet activation. And remember, what the platelets, once they get attached to the collagen fibers on here, they will become activated and they will start to release chemicals. The platelet activation here is what's going to be stimulating the activation of the coagulation factors, which are normally located in your bloodstream. They are plasma proteins. And the very first coagulation factors that gets activated in the intrinsic pathway was coagulation factor 12. If you remember, activated coagulation factor 12 activates coagulation factor 11. Activated 11 activates coagulation factor 9. That once activated activates coagulation factor 8. Concerning the extrinsic pathway, if you remember, something is taking place outside of the blood vessels, and those are the injured cells. Those injured cells are going to be releasing a chemical. We call this is my tissue factor, and this is released from my tissues outside of the blood. And if you remember, tissue factor is going to be activating factor 7 that once become activated is going to be forming a complex along with the tissue factor. The same takes place in the intrinsic pathway, I'm sorry, where I have both activated 8 as well as activated 9, going to be forming a complex. Both activated 7 and tissue factor have the ability to activate factor 10. And activated 8 and 9 also, when forming a complex, they will be able to activate factor 10. So both intrinsic pathway and extrinsic pathway gonna end up activating factor 10. Activated 10 activates also factor 5. And if you remember, activated 10 is what we've called the prothrombin activator. And if you remember from the name, prothrombin activator is activating prothrombin into thrombin. Thrombin 2 is the one who is responsible to convert the soluble fibrinogen, which normally circulates in my bloodstream. It's soluble, so you don't notice its presence, into its insoluble form, which is my fibrin. And the fibrin that is insoluble is going to be presenting itself in the form of connective tissue fiber threads, like this. This is not the final shape of the blood clot. If you remember, you need to use the fibrin threads that you did build in order for you to form a cross-linked fibrin mesh to form your blood clot. And if you remember, coagulation factor 13 is the one who's going to be responsible to build those connections between the fibrin threads in order for you to use them to build your fibrin mesh. Remember, located between those fibrin threads, I still have the platelets that were forming the platelet plug. And those platelets contain contractile myofilaments called the actin and the myosin, like the ones that you have in your muscle cells. If you remember, those platelets, they will start to contract, pulling those fibrin threads, building up my blood clot closer to one another. And this will allow you to stabilize your blood clot, make it more tough, and this will allow me to squeeze out the serum from the blood clot. And this explains why your blood clot will be shrinking within 30 to 60 minutes from its formation, because simply the platelets in between the fibrin threads will contract, squeezing out the serum and pulling those fibrin threads closer to one another, forming this strong blood clot that seals my injured vessel. We call this step is the platelet It's the blood clot retraction. Blood clot retraction again is taking place between 30 to 60 minutes within the platelet, within the blood clot formation. So I did seal the injured vessel. So now this is the vessel that got injured. This is how it looks like. If you remember, the inside of the blood vessel is lined with simple squamous epithelium, my endothelium, that got disrupted at the site of injury, where I've got the blood clot in here. Other things that will be located in your blood vessel, if you remember, underlying your epithelium, you've got connective tissue to support the epithelial lining. And the exposure of those collagen fibers to the platelets is what activated the platelets in the first place. Another thing that was located in my blood vessels, it was my smooth muscles that will allow the blood vessels, if you remember, to contract and relax, performing vasoconstriction and dilation. So three main components that are building the wall of the blood vessel, and those are disrupted at the site of injury on here. So I did seal the vessel, I closed the vessel, it's not leaking blood anymore. This is a function of the blood clot. But what would you like to do after you stop bleeding? You need to rebuild your tissues in order for you to get rid of the blood clot. So how would I repair a blood clot? First, I need to have two main growth factors. First one is going to be released from my platelets. So we call the first one is my platelet-derived growth factor. And this was one of the granular contents of my platelets. Platelet-derived growth factor, it's going to be stimulating both the smooth muscle cells to proliferate and will be enhancing the fibroblasts, which are the cells responsible to build up my connective tissue, to build the connective tissue back into my blood vessel wall. Another type of growth factors that I have is the ones that will be released from the endothelium itself. The endothelium is going to be releasing its own growth factors. So the living endothelial cells around the injured site are the ones that will be stimulating themselves to replicate and to cover this injured site. So we call the growth factor in here that gets released from the endothelial cells that will be stimulating the endothelial cells to restore the endothelial lining of the blood vessel. It's called my vascular endothelial growth factor. So in order for me, again, to rebuild my blood vessel, to repair the blood clot, I have two main growth factors. First one is going to be released from my platelets. This is my platelet-derived growth factor. The second one is released from the endothelial cells, and it will be affecting also the endothelial cells. This is called the vascular endothelial growth factor. So what would you do with this blood clot? Would you like to keep this blood clot forever, sealing your vessel, or do you want to break it down? What do you think? Would you like to keep it forever, or would you like to break it down? While you are restoring the normal tissues in your blood vessel, would you like to keep it or break it down? You would like to break it down. The process by which you're going to be breaking down the blood clot is what we call fibrinolysis. Fibrin is a type of protein threads that form the blood clot. And lysis to lyse is to break down. So the process by which you're going to be breaking down the blood clot is what we call the fibrinolysis. The process here starts within 2 days of the blood clot formation. How do I break down the blood clot? I'm using an enzyme called the plasmin. Plasmin is normally present in my circulation in an inactive form called the plasminogen. And in order for me to activate the plasminogen into plasmin that would be breaking down the blood clot, digesting those fibrin threads and breaking down the blood clot, I need tissue plasminogen activator, or TPA. Also, activated factor 12 and the thrombin. So if you notice on here, tissue plasminogen activator, it's gonna be released from my injured cells, like the tissue factor. So you've got tissue plasminogen activator getting released from my injured cells. So you're gonna be forming tissue plasminogen activator once you've got an injury. Also, factor 12 is going to be enhancing the blood clot degradation and lysis. Another factor on here is going to be the thrombin. So if you notice on here, I have got something released from the injured cells. I've got something from the intrinsic pathway, the activated factor 12, and I've got something from the common pathway, which is the thrombin. So if I'm telling you that those factors that cause the formation of the blood clot are the same ones that are enhancing its breakdown, does this mean I form a blood clot or not? What do you think? If I'm telling you that the same factors that will be forming the blood clot are the same ones that are breaking down the blood clot, would I be forming a blood clot in this case? What do you think? Again, my question, we have seen intrinsic pathways that allows the formation of a blood clot. We've seen extrinsic pathway also allows the formation of a blood clot, and both of them are gonna meet and will form the blood clot through the common pathway. So I've got factor 12. It was one of the coagulation factors that get activated in the intrinsic pathway. Injured cells are going to be releasing tissue factor. Also, they are releasing the tissue plasminogen activator, which enhances the blood clot degradation. Thrombin here is the one that will be transforming the soluble fibrinogen into fibrin, allowing the blood clot formation, but in the same time, thrombin also going to be activating the plasminogen into plasmin for me to degrade and break down the blood clot. So how come am I able to form a blood clot if the same things that allow me to form a blood clot are enhancing its breakdown? Can somebody explain this to me? What do you think? Any guesses? Any guesses? So my question here in another way. So if I'm telling you I will be moving forward and backward, would there be any movement I will be ending up with? I'm telling you I am forming a blood clot and I will be breaking down the blood clot. Will there be any blood clot that gets formed? If I'm moving forward and backwards, would there be any forward movement? It's according. So the trick here, if I told you I will be moving forward 5 feet, but backward I will be moving 3 feet. So what's going to be the final movement that I will be performing? It's going to be the difference between the two, which is the 2 feet. This is the same exact concept. Yes, the same factors that are forming the blood clot are also breaking it down, but I got a blood clot formed because of the difference in the speed between the formation and the destruction. So formation is much faster than the destruction. So what I will have the blood clot for is the difference between the speed of formation and the speed of destruction. That's why we form a blood clot. Although the same factors that forms a blood clot are also enhancing its breakdown. All right. So both processes are going to be starting in the same time, but one, the breakdown is going to be effective within 2 days. Why? Because it's much slower. So I've got activated 12, I've got tissue plasminogen activator, all at the same time of the formation. Starting the stimulation here of the plasminogen into plasmin to degrade, but I won't notice any breakdown until 2 days of the formation. Why? Because the formation is much faster than the destruction. So don't get confused when you read how come tissue factor is the one that enhances the formation of a blood clot. It's also enhancing its breakdown. How come the thrombin that actually transforms the soluble fibrinogen into insoluble fibrin, forming the blood clot, gonna be enhancing the blood clot breakdown? Yes. I will be enhancing the blood clot breakdown as well as formation, but keep in mind that there is a difference in the speed between the formation and the destruction. That's why I will end up having a blood clot formed for a specific amount of time, and then it gets degraded. Is there any logic here why the same factors that allow you to form the blood clot gonna enhance its breakdown? Is there any logic here? Is it logical? Is it logical? My opinion, it is so logical. Why? Because your body knows already that you want to form a blood clot that's gonna remain forever. So there is no blood clots that you're gonna form that's gonna remain forever. This means that every blood clot needs to be broken down later. So the same factors that allow the formation to ensure its breakdown are the ones who also enhance the breakdown of the blood clot. So it is so logical that the same factors enhancing the formation of the clot are also enhancing its breakdown. Clear concept? Any questions? All right, so factors limiting the clot growth and formation. So why, if I've got an injured vessel in here, Why this blood clot is going to be limited to the injured site and it's not going to be progressing, forming a very large blood clot, activating the fibrinogen throughout my circulation and forming blood clots everywhere in my intact vessels. We have two main factors here that will allow you to limit the growth of the blood clot. First is the removal and dilution of the coagulation factors. Remember, where do I have activated coagulation factors? Whenever I have injured cells and activated platelets. And where do I have activated platelets and injured cells? At the site of injury. So I don't have them throughout my circulation. So the activation is going to be mainly localized at the site of injury. And as I move away from the site of injury, those chemicals that will enhance the activation of the coagulation factors going to be removed and diluted. So they won't be effective away from the site of injury. Another factor is that you have blood clot inhibitors, blood clot formation inhibitors circulating normally in your bloodstream. This includes antithrombin 3, protein C, and heparin. Those are normally present in the circulation, ready to react with any blood clot that is about to get formed anywhere away from the injured site. That's how I limit the blood clot growth and formation. Factors that would be preventing the formation of blood clot in intact vessels. This includes that you don't have activation of the platelets in intact vessels. Remember what allowed the activation of the platelets to take place? If you remember, I've lost my endothelial lining, exposing the underneath collagen fibers. And those collagen fibers will form a rough surface for the platelets to adhere and to become activated, starting the formation of a blood clot through the intrinsic pathway. So normally, I don't have a blood clot that is getting formed in intact vessels because simply I have this very smooth endothelial lining that will be preventing the platelets from getting attached. So this won't be present in something like patients with atherosclerosis. Patient with atherosclerosis is accumulating fat underneath the endothelial lining. We call those are the atheromatous plaques. They might rupture, causing the exposure of this rough surface. This is where platelets can adhere and start a coagulation process, although this blood vessel is intact, it's not injured. So I will start to form a blood clot in an intact vessel, might result in a stroke, might result in a myocardial infarction. All right, so normally why this doesn't happen? Because simply you've got this smooth endothelial lining covering the inside of your blood vessels. You've got also anti-thrombic substance. This includes nitric oxide and prostacyclin. Vitamin E kinine also acts as an anticoagulant normally present in your body. What if a person has lost part of his blood volume and you wanted to restore his blood volume? So what we're going to be giving the patient? First thing, in order to restore the blood volume, we might consider giving normal saline. Why normal saline? Normal saline has the same osmolarity as your body fluids. Remember, your intracellular fluid compartment has the same osmolarity like your extracellular fluid compartment. If you've given just water, IV, what's going to happen? The water going to be moving from the extracellular fluid to the inside of your cells, and your cells going to be swelling. You don't give water, you're going to give normal saline. Why normal saline again? Because it mimics the osmolarity of the plasma. So there will be no net fluid gain or loss out of my cells. So I will not be gaining fluid into my cells. So my cells will be able to keep their shape. Nothing going to change. Neither they will be sweating or they will shrink. Also, something that we might consider is going to be the plasma expanders. And plasma expanders are like the purified human serum albumin, hetastarch, and dextran. The purified human albumin is a protein released from the liver normally. It has a very strong osmotic pressure, and in order for me to expand the blood volume, I might be considering giving the patient purified human serum albumin in order for the albumin to pull water into my vessels without having to phase. So if I have albumin in here, it's like the sodium, it's going to be pulling water. So instead of giving fluid to this patient from outside, I will give albumin, and the albumin is going to be pulling the water into my vessels from the surroundings. This is especially important if the patient has fluid building up somewhere else, like edema, for example. So if a person has edema, has liver cirrhosis, liver destruction, he's accumulating fluid outside in the interstitial fluid compartment. So I want to pull this fluid back into the vessels rather than being located between the cells. So in order for me to pull this fluid and restore the blood volume, I would be considering giving the purified human serum albumin. Hetastarch and dextran, those are sugars that will mimic the osmotic properties of the albumin. But the problem with the hetastarch and dextran, they are more expensive and they might cause more complications than using just albumin. So why do you even consider them? What do you think? If albumin is much better, has less complications, less expensive, so why would you put hetastarch and dextran as choices here? What do you think? So if I'm telling you, we have two phones. This one is much better and it's cheaper. This one is less better and it's much more expensive. Would anybody consider this one? Let's see, this is number 2. Would anybody consider this one and why? What do you think? Nobody will consider it, right? So why do you still have it on the market? Simply because this one is not available in all cases. So in many cases, I might not have purified human serum albumin. So where do you get the purified human serum albumin? It's from blood donations. So in some cases, I might not have blood donations, so I'm not able to get the albumin. So I will consider giving hetastarch and dextran instead, which are sugars again that will mimic the osmotic properties of the albumin. Does this make sense? Questions? Questions? All right, so moving on to the blood transfusions. Whole blood transfusion is going to be used in case of blood loss. So if a person lost in a car accident, for example, large amounts of blood, this patient going to need to get whole blood transfusion. In patients with low oxygen carrying capacity, anemias for any reason, hemolytic anemia, for example, so he has premature destruction of the red blood cells, I might consider only giving him red blood cells. We call the blood transfusions that consists only of red blood cells. This is the packed red blood cell transfusion where I removed the plasma from the blood. So I'm not willing to overload the heart with extra fluid. I will only be giving the patient here packed red blood cells. Also, in some cases, I might consider giving patients just plasma, especially if they have missing coagulation factors, for example, like having hemophilia. So I will be only in need to give them plasmas that contain the different plasma proteins rather than giving them a whole blood transfusion because this might cause an iron overload. Remember, iron is recycled. You don't get rid of the iron. So if you kept getting just blood transfusions, you are getting red blood cells. And the more red blood cells you're going to be getting from outside, the more iron that you're going to keep in your body because the iron is going to be recycled over and over and you're not getting rid of it. So in order for me to not have iron overload, I will consider only giving this patient plasma instead of a whole blood transfusion. Moving on to a really important topic, is this going to be the human blood groups. In this topic, we are discussing two major blood grouping. First one is the ABO blood grouping. First thing we need to understand is what is an antigen. An antigen is a chemical marker that can trigger a chemical molecule that can trigger an immunological response. This is what I call an antigen. And this is how your body recognizes itself. So my cells are capable to recognize other cells in the body that those are mine and not coming from outside because they are presenting on their surface self antigens. If you've given me cells that doesn't belong to me, my immune system will recognize that this is a non-self antigen and it will start to attack it. So how your body recognizes a bacteria, for example, the bacterial cell contain non-self antigens. So whenever your immune system recognizes the antigens presented on the surface of the bacterial cell, it starts to create an immunological response and attack this bacterial cell. Same concept if I'm getting a mismatched blood transfusion. What's a mismatched blood transfusion? I have got a type of antigen that doesn't exist on my cells. So my immune system will recognize it as a non-self antigen and will start to attack the transfused cells. For the ABO blood grouping, I have 4 blood types. Being a blood group type A means that my red blood cells are representing on their surface only antigen A. Being a blood group type B means that my red blood cells are only presenting antigen B on their surface. Being a blood group type AB means that my red blood cells are presenting both antigen A and antigen B on their outer surface. Being a blood group O means that my red blood cells are neither presenting antigen A or antigen B. I neither have antigen A or antigen B. So when would a mismatched blood transfusion takes place? Whenever, again, a non-self antigen is presented to your immune system. Means what? Means that you've got exposed to an antigen that doesn't exist on your cells. So while we are performing a blood transfusion, we need to be aware of what? We need to be aware to not give a person an antigen he doesn't have on the surface of his cells. Why? Because if you've given me an antigen that I don't have on my cells, what's going to happen? My immune system will start to recognize this antigen as a non-self antigen, and I will start to form immunoglobulins or antibodies that will be attaching themselves to the antigen. So for example, this is how it's going to look like. If this is a transfused cell, I don't have antigen A on my red blood cells. So antigen A for me is a non-self antigen. And you've given me a blood transfusion containing red blood cells type of a blood type A. So what will I do? My immune system will recognize the non-self antigen, which is antigen A. I don't have antigen A on the surface of my cells. And I will start to produce immunoglobulins that will be binding to the antigen like this. If you remember, how many red blood cells can pass through the diameter of a capillary at a time? How many red blood cells can pass through the diameter of a capillary? Just one, right? So if you are attaching 5 or 10 red blood cells, what's going to happen to those blood cells as they are squeezed through the tiny diameter of the capillaries? They will rupture. So in a mismatched blood transfusion, what happens? You are forming immunoglobulins that will be binding multiple red blood cells at the same time. And as you push those red blood cells into the tiny diameter of your capillaries, what's going to happen? Those red blood cells going to rupture and will release their content. And what is the content of the red blood cell? Can you remind me what you have mainly inside your red blood cells? Do you remember what was the name of the pigment that will be carrying the oxygen in your red blood cells? hemoglobin, right? The hemoglobin, if you remember, it's inside the red blood cell. It's not supposed to circulate freely in your bloodstream. So whenever I have a rupture of my red blood cells, what's going to happen to the hemoglobin? It's going to be free, circulating in my blood. And what is the problem with having hemoglobin circulating freely in my circulation? The problem here is that the hemoglobin, it's not a plasma protein, it's not a cell, it's not a macromolecule, so it gets filtered in the kidney tubules. And this free hemoglobin, once it gets filtered, it's going to be blocking the kidney tubules, causing renal failure. So what is the problem again with a mismatched blood transfusion? Again, my immune system, if I get exposed to a non-self antigen, it starts to form immunoglobulins against this antigen, attaching multiple red blood cells together. This will cause the rupture of the transfused red blood cells and the release of the hemoglobin. And remember, hemoglobin normally doesn't get released in the bloodstream. It gets released within the liver or spleen, where normally the red blood cell destruction is taking place. So if I got hemoglobin released freely in my bloodstream, the hemoglobin here gonna be filtered in the glomerulus, blocking the kidney tubules, preventing any further filtration from taking place. And as a result, this patient might end up having renal failure. So who can get from whom, considering this? The key again, don't give an antigen to a person who doesn't have the antigen on his blood cells. In other words, he is capable to form antibodies against the antigen. So who is the non-self antigen? If I'm a blood group type A, I have antigen A on the surface of my cells. So what is the antigens that I would consider non-self antigen? What antigen I don't have on my cells, it would be considered a non-self antigen. What do you think? Remember, how many antigens am I dealing with? I'm dealing with only two antigens, A and B. A and B, when present together, I have a blood group type AB. This is not an antigen. There is no antigen called AB. We have two antigens, either A or B. So which one I don't have on the surface of my red blood cells? If I'm a blood group type A, I don't have antigen B. So antigen B for me is a non-self antigen, and I will be forming immunoglobulins against antigen B, anti-B. When I say anti-B, means what? Means antibodies against B. Don't get confused. Anti-B, it's not antigen B. Anti-B means antibodies against antigen B. So how about if I'm a blood group type B? What antigen I don't have on the surface of my cells is a non-self antigen for me. What antigen I don't have on the surface of my cells? If I'm a blood group type B, what is the antigens that doesn't exist on the surface of my cells that I would consider a non-self antigen? Exactly, antigen A. So which immunoglobulin would I be forming? Which antibody would I be forming? I would be forming anti-A, because antigen A is not presented on the surface of my cells. It's a non-self antigen. So my immune system, once it gets exposed to antigen A, it starts to produce antibodies that will attack antigen A. How about if I'm blood group type AB? Which one of the two antigens I don't have presented on the surface of my red blood cells? Which one of the two antigens? Which one of the two antigens would you consider a non-self antigen? What do you think? How many antigens do I have? Do I have something called antigen O? Do I have something called antigen O? Do I have something called antigen O? O means you don't have A or B. O, it's a zero, zero. You don't have A or B. There is nothing called antigen O. All right, so which one I don't have on the surface of my cell? I have antigen A, I have antigen B. So would I be producing anti-A? No. Would I be producing anti-B? No. Why? Because both of them are self-antigens. Both antigen A and antigen B are self-antigens, so you're not going to be forming antibodies to attack yourself. All right, so here, which antibody would I have in the blood? I don't have neither anti-A or anti-B. How about if I'm blood group type O? If I'm blood group type O, which one I don't have presented on the surface of my cells? Which one? Which one I don't have presented on the surface of my cells? Which ones are non-self antigens for me? Both A and B are non-self antigens. So which antibodies would I be producing if I don't have antigen A, if I don't have antigen B? Which antibodies would I be forming if I'm a blood group type O? Which antibodies? Anti-A and anti-B. So if I get exposed to antigen A, I will start to attack it. If I got exposed to antigen B, I will start to attack it. So who can receive from whom a blood transfusion? So let's check on here. Again, what is the rule? Don't give an antigen to a person who is capable to produce an antibody against this antigen. This is my rule. You tell me here. Can I receive blood if I'm a blood type A? Can I receive blood from another person who is a blood group type A as well? Yes or no? If I'm blood group type A, would I be able to receive blood from another person who is a blood group type A, like me? Yes. Why? Because I'm getting what antigen? I'm getting antigen A. Do I produce anti-A? No, you don't produce anti-A. So you don't have a problem. We didn't mention anything about positive and negative yet. We didn't mention anything about positive and negative yet. All right. How about giving me a blood type B? If I'm a blood group type A. No, why? Why you won't give me blood type B? Because the antigen that you have on the surface of the red blood cells is antigen B. It's gonna meet the antibody. I don't have antigen B on the surface of my cells, so antigen B for me is a non-self antigen. I will be producing anti-Bs that will attack the red blood cells containing antigen B. Can I receive blood from a person who is a blood group type AB? What do you think? I'm a blood group type A. I have antigen A. Can I receive blood from a blood group type AB? Yes or no? Yes, yes, no. What do you think? Yes. So what is the rule? Can you remind me of the rule? You don't give a person an antigen that he can produce antibodies against, right? So what antigens are carried on a blood group type AB? What antigens do I have? I have both antigen A and antigen B on the surface of my cells. So would the antigen meet an antibody? What do you think? Would the antigen meet an antibody that I'm producing? If I have A and B, so I have antigen B on the surface of the transfused cells. So what's going to happen? Antigen B will be attacked by anti-B, and this will cause the red blood cells to be destroyed. Would you like me to get blood type AB if I'm blood group type A? Yes or no now? Definitely not. Why? Because antigen B is presented on the surface of the cells, and I am producing anti-B, which will cause the destruction of those cells that are presenting antigen B. Anti-B attacks antigen B. So you can't give me a blood type AB if I'm a blood group type A. Can you give me a blood group type O? What do you think? What antigens do you have on a blood group on the red blood cells of a blood group type O? You don't have antigens. If I don't have antigens, would there be a problem getting those red blood cells? What do you think? Again, don't, the rule says what? Don't give an antigen to a person who's producing antibodies against this antigen. Do I have an antigen on the red blood cells type O? No antigen. So can I get the blood cells? Because when would you have a problem? If you have antigen meeting the antibody. If I don't have antigen, would this happen? An antigen to meet its antibody? No. So can I get blood type O if I'm an if I if I have a blood type A? Yes. Why again? Because I don't have an antigen, so there will be no exposure to a non-self antigen for me to attack. How about if I'm blood group type B? Can I receive blood from a blood group type A? What do you think? Yes or no? No. Why? Because antigen A is going to meet anti-A and the cell is going to be destroyed. Can I receive blood from a blood group type B? What do you think? Can I receive blood from a blood group type B? Yes, I can. Why? Because a blood group type B carries antigen B. I don't have anti-B. I have B on the surface of my cells, so I will not be attacking antigen B. Can I receive blood from a blood group type AB if my blood type is B? What do you think? No, why? Because see on here, you've got antigen A on the surface of your cells, and your immune system can produce anti-A. So those cells, the transfused cells, are going to be attacked and destroyed. So you can't get blood from an AB blood type. Can I get blood transfusion from an O person? What do you think? Can I get a blood transfusion from an O person? I don't have neither A or B on the surface of my cells. So there will be no problem. When would I get a problem again? Whenever an antigen meets its antibody. So blood group type O doesn't have antigen A or B, so I won't have a problem. So yes, I can get a blood transfusion from a blood group type O if I have a blood group type B. What if I'm a blood group type AB? Can I get blood from an A blood type? Yes or no? Yes. Why? Because I'm getting antigen, and I don't have an antibody against this antigen, so there will be no problem. Can I get blood from a B person? Blood group type B has antigen B on the surface, and I don't have any antibodies, so there will be no attacks to the transfused cells. So can I get blood transfusion of a blood type B? Yes. There will be no antigen antibody reaction. How about getting a blood transfusion from an AB blood group? What do you think? Is it safe? Is it safe? Yes, no problem. AB antigens will be transfused, but I don't have any antibodies, so there will be no reaction. So yes, definitely I can get blood group type AB. Can I get blood group type O transfused to a person who is a blood group type AB? What do you think? No antigens are meeting no antibodies, you don't have a problem. I don't have an antigen to react with the antibody. Blood group type O means you don't have antigens. AB, you're not going to be producing neither anti-A or anti-B. Both are presented on your cells. So you don't have any antigen-antibody interaction. So is it safe to give a blood group type AB an O blood group and an O blood transfusion? Yes or no? Again, one last time. Yes. How about blood group type O? I don't have antigens on the surface. So both antigen A and antigen B for me are non-self antigens, and my immune system is forming anti-A and anti-B. Can you give a blood transfusion of a blood type A to an O blood type? No. Why? Because A antigen gonna meet anti-A, and this will cause the destruction of the transfused cells. How about, can I get blood group type B? No. Why? Because blood type B gonna contain B antigen on the surface of the red blood cells, which will meet anti-B, which will cause their destruction. So I can't get blood group type B to an O person. Can I get blood group type AB to an O person? No. I have both antigen A and antigen B on the surface of the transfused red blood cells, and this is going to result in a reaction with anti-A and anti-B produced by my immune system. Can I get a blood group type O transfused to an O blood type? Yes or no? Yes. Why? Because I don't have an antigen, so there will be no reaction with the antibodies I have. All right? This is very, very important for the upcoming lab exam. You need to understand the fundamentals here of the mismatched blood transfusion and the transfusion reaction. It's highly important to know which blood type I can give to each of the 4 blood types in a blood transfusion. Highly, highly important. Any questions? Any questions? How about somebody was asking about the A positive and A negative? What is the positive and negative? It's a different blood typing. Because this is the RH. RH. So being an RH positive means what? Means that my red blood cells are presenting antigen D on their surface. Being an RH negative means that my red blood cells are not presenting antigen D on their surface. So again, what is a positive and a negative? It's different blood typing. All right, so we're looking here. If I am an RH positive, means I am representing antigen D on the surface of my red blood cells. If I don't have antigen T presented on the surface of my red blood cells, I am an RH negative. All right, so antigen D, if I'm looking here at the genetics behind the RH, if you remember, your chromosomes are arranged in pairs. So you've got one set of chromosomes from your father and the other set from your mother. So you have 23 pairs of chromosomes. One set of 23 chromosomes, you've got them from your mother, and the other 23 chromosomes are from your father. So if you've received the chromosomes that is gonna contain the gene coding for the antigen D, on both chromosomes, so the one from your father and the one from your mother carries a gene coding for antigen D, you're gonna say that you are D capital D capital. And you're gonna be an RH positive because the gene that exists on your chromosome is gonna be expressed by forming antigen D that gets presented on the surface of your red blood cells. What if you've got only one copy of the gene coding for the D antigen? So for example, the chromosomes that you got from your father, it's gonna carry the gene coding for the D antigen, but the ones that you've got from your mother doesn't carry the gene coding for the D antigen. So what we're gonna write down here as a genome, we're gonna say it's D capital D small. This means that you only have one copy of the gene coding for the D antigen. If you only have one copy of the gene coding for the D antigen, you're still gonna be presenting the antigen on the surface of your cells. In other words, you are RH positive. So being RH positive means you are either D capital means you have two copies of the gene coding for the D antigen present on both chromosomes, the ones that you get from your father and the ones that you get from your mother. Or you might be D capital D small. This means that you have only one copy of the gene coding for the D antigen on either chromosomes. Either you get the gene from your mother or you get it from your father, but you only have one copy of the gene coding for the D antigen in your genome. Being RH negative means what? Means that both of your chromosomes, the ones that you get from your father and the ones that you get from your mother, they don't have the gene coding for the D antigen. So we're going to say it's D small, D small. Would I be presenting the D antigen if I don't have the genetic code for the D antigen? No. If I don't have the gene coding for the D antigen on the surface of my chromosomes, there will be no antigen D presented on the surface of my red blood cells, and we call this as an Rh negative. So anyone who is Rh positive, you might be either D capital D small or D capital D capital. Means what? Means you either have one copy of the gene or two copies of the gene. Being Rh negative means that on your chromosomes, you don't have any gene coding for the D antigen, and as a result, you're not expressing the antigen D on the surface of your red blood cells. What is the clinical application on here of Rh negative and positive? So let's see on here, a couple just got married. Female is Rh negative, means what? Means she doesn't have the gene coding for the D antigen. And the male here has the gene coding for the D antigen on both chromosomes. So all his sperms gonna carry a chromosome that contain the gene coding for antigen D. And she being an Rh negative, all her eggs gonna carry a chromosome that doesn't have the genetic code for the D antigen. All right, so those are all his sperms, and this is all her eggs. So 100% of their offsprings gonna be D capital D small. This means what? That all of their children gonna be Rh negative or positive. What do you think? If I am D capital D small, am I Rh positive or am I Rh negative? Positive. So all of their children are Rh positive. All of their children are Rh positive. Is there something wrong here? Nothing wrong so far. So this couple just got married, and now this is female. Now she is pregnant. Congratulations. So her baby is Rh positive. And she is Rh what? The mother here is Rh what? Rh negative or positive? Negative. So the mother is Rh negative, the baby is Rh positive. So the baby carries on his red blood cells the D antigen, but the mother's red blood cells don't have the D antigen. Remember, whenever the immune system gets exposed to an antigen that you don't have on your cells, it's going to be considering this antigen as a non-self antigen, and you're going to start attacking this antigen, right? So antigen D for the mother here, it's a non-self antigen. It's a non-self antigen. Do I have a problem during pregnancy? Is there any exposure to the antigens of the baby by the mother's immune system? Does the mother's immune system gets exposed to the antigens of the baby during pregnancy? Yes? Any other guesses? What do you think? Do you carry the same antigens like your mother? What do you think? Do you have the same exact genetic material and the same exact antigens presented on your cells like your mother? Remember, you are not an identical copy of your mother. You are just 50% from your mother and the other 50% from your father. So you're not identical to your mother. So do you have the same antigens, same exact antigens like your mother presented on your cells? Definitely not. You don't. So why your mother's immune system didn't attack you during pregnancy? Because it doesn't get in direct contact with the baby. So during pregnancy, is the mother's immune system getting exposed to the baby? Yes or no? Do I have exposure between the baby cells and the mother's immune system during pregnancy? Yes or no? No, there is no exposure during pregnancy. If there was exposure, every mother's immune system gonna kill every baby because you don't express the same antigens like your mother. So my question again, I want a lot of responses here. I want to make sure that you got this. Do you have an exposure of the baby antigens to the mother's immune system during pregnancy? Yes or no? No. No. There is no exposure. So would there be anything wrong with this baby if the mother's immune system doesn't see those red blood cells? Would there be any problem? There would be no problem. There is no problem. So congratulations, this baby is healthy and has nothing wrong with him. But what happens during labor, during delivery? Some of the red blood cells of the baby gonna be passing to the bloodstream of the mother. So during labor, there will be wounds, detachment of the placenta. So some of the red blood cells of the baby will escape and will reach the mother's circulation. Now I've got exposure. When? Not during pregnancy. The baby is getting out, and now I've got the first exposure. So as the mother gets exposed to the antigen D, it's gonna her immune system gonna consider it as a non-self antigen. She doesn't have antigen D on the surface of her red blood cells. So she will start to form after exposure, not before exposure, after she gets exposed to antigen D from her baby's red blood cells that got escaped to her circulation during labor. She will start to produce anti-D. And anti-D immunoglobulins are small immunoglobulins of a type that we call IgG. So those are IgG type of immunoglobulins, of antibodies. Is there anything wrong so far? Anything wrong so far? No, the baby is healthy. Everything seems fine. But when would I have a problem? if this mother, the same mother, got pregnant again and her baby was Rh positive, this is the second baby on here. First one is totally fine. I have no problem with him. The problem here with the second pregnancy or any later pregnancy. Why? Because your immune system has a memory, an immunological memory. So the mother's immune system gonna keep producing anti-D for the rest of her life. What is the problem now? That anti-D immunoglobulins can travel through the placenta. They are IgG types. They are smaller in size than other types like IgM, for example. So IgG immunoglobulins can travel through the placenta. So they will find their way from the mother's circulation to the baby circulation. And what would they do when they get exposed to the baby red blood cells? Remember, this second baby is also Rh positive. So his red blood cells gonna be presenting antigen D on the surface. So once the immunoglobulins encounter antigen D on the surface of the red blood cells, they will mark those red blood cells for destruction, and the baby's red blood cells gonna be destroyed. This is gonna result in a problem that we call erythroblastosis fetalis. So let me check on here. To give you an impression about how the baby is gonna look like. All the red blood cells going to be attacked by the immunoglobulins. Baby will have edema, swelling, yellowish discoloration of the skin due to the high bilirubin formation. See, yellowish discoloration of the skin, edema and swelling to the whole body due to the inflammatory response. Most of the cases going to be a stillbirth. So how can we avoid such thing from happening? How can I avoid this? Somebody was saying about the RhoGram shot earlier. So what is a RhoGram shot in here? That each Rh negative woman will be taken late in her pregnancy and during labor. This is simply an anti-D from outside. And its main function is to prevent the very first exposure. So I'm hiding the red blood cells of the baby from the mother's immune system for the mother's immune system to not form its lifelong memory. So with every pregnancy, with every miscarriage, where every time mother here gonna get a RhoGram shot, which is simply an anti-D antibody. And the main function is to destroy the blood cells that escape from the baby during labor to prevent the mother's immune system from forming anti-D for the rest of the mother's life. All right, so I will do this with every pregnancy, with every miscarriage, any time the woman here got pregnant, I need to prevent her from getting exposed to the antigen D from the baby during labor. All right, questions? All right, so this is going to be the essay question for the upcoming lab exam. So erythroblastosis fetalis, I will be asking you about what are the circumstances that will cause the development of erythroblastosis fetalis, how do we prevent it, and you're going to need to explain that the father going to be Rh positive, the mother is Rh negative, first baby is going to be free from any problems. The problem is with any later pregnancy after I got the first exposure to the antigen D. So Rh positive can receive Rh negative. Yes, so when you apply the rule, what is the rule again? Don't give an antigen to a person who is producing antibody against this antigen. Don't do this. So if you are Rh positive, this means what? You have on the surface of the red blood cells antigen D. And being Rh negative means what for me? Means I don't have antigen D on the surface of my cells. So my immune system will recognize antigen D as I don't have it as a non-self antigen and will be producing anti-D whenever it gets exposed to it. So who can receive from whom? If I'm a blood group Rh positive, if I'm Rh positive, can I receive blood from an Rh negative person? Can I receive blood from an Rh negative person? Would I have any problem? And do you give me the antigens that I don't have on the surface of my cells or I'm producing an immunoglobulin against? Yes or no? What antigen are you giving me? Are you giving me any antigen being Rh negative? Are you giving me any antigen? No. So would you have a problem if you're not giving me an antigen? Would I have a problem being Rh positive? No, because the antigen that you're not giving me will not meet the antibodies that doesn't exist. Right? When would you have a problem? Whenever an antigen meets antibody. If you're not giving me an antigen and I'm not producing an antibody, would there be any problem? No. All right. So yes, an Rh negative can give a blood transfusion, blood to Rh positive. How about the reverse here? Can Rh positive give blood to an Rh negative? Here, you're giving me antigen D, and I'm producing anti-D. Would the antigen meet the antibody? Yes or no? Yes. If there is an antigen antibody encounter, when they encounter each other, what's going to happen to the transfused cells? They are going to be attacked and destroyed. So would you be given Rh positive blood to an Rh negative person? Yes or no? No. But when would you be forming anti-D? After the first exposure. So if you are somewhere where you don't have access to blood, for example, and you've got a blood type A, for example, negative, and a person, you've got a bag of blood, which is our blood group type A positive. And the patient here did bleed a lot and he needs a blood transfusion. Would you give, knowing that he has never received a blood transfusion before? So this patient here who lost a lot of blood, he's A negative. He didn't, you know already that he didn't get a blood transfusion before. And the only blood that you have available is A positive. Would you give RH positive to a person who is RH negative if he is about to die and you don't have access to any other blood and you know that he didn't receive blood transfusion before? What would you do? Yes, it will pass only for one time. This blood will save this patient, but this patient is going to build a lifelong immunological memory against RH positive. So if this was a female here, if she got married to an RH positive person, all her babies are gonna be at risk of developing erythroblastoma fetalis because she got exposed to RH positive before, even with the first pregnancy. Even for her first pregnancy, if you did already give her a blood transfusion using RH positive, she has already developed antibodies against the antigen D. All right, so the very first baby in this case will develop erythroblastoma fetalis. Does this make sense? Questions? Questions? But this doesn't apply for ABO blood group, as ABO blood groups are going to be resulting in the formation of antibodies at about the second month of age. By the second month of age, if you are blood group type A, you're gonna develop anti-B. If you are blood group type O, you're gonna develop anti-A and anti-B. If you are blood group type B, you're gonna develop anti-A. Again, all this is gonna be second month of age. By the second month of age. So even for the first mismatched blood transfusion, you're going to have a reaction causing the destruction of the transfused cells and renal failure. So again, if we're looking here at a blood group type AB, I have both antigen A and antigen B on the surface of the cells. So I won't have neither anti-A or anti-B. If I'm blood group type B, I have only antigen B presented on the surface of the cells. So I would be forming anti-A and only anti-A antibodies. If I'm blood group type A, this means I have only antigen A presented on the surface of my cells, and the ones that I don't have is antigen B that I would be forming immunoglobulins against. So I would be forming anti-B. Being a blood group type O, I don't have neither antigen A or B on the surface of my cells. So both antigens are non-self antigens for me. So I will be forming anti-A and anti-B. Remember, blood group type AB can receive blood from everybody. This is what we call a universal recipient. And blood group type O. Remember, I don't have any antigens, so blood group type O can give blood to all the other three blood types. This will make the blood group type O the universal donor. So again, who is the universal recipient? It's blood group type AB, and who's the universal donor is blood group type. So how would I test blood for the ABO blood grouping? I will be simply putting the blood that I'm testing on anti-A and anti-B. If I've got an agglutination reaction like what you see on here, if the red blood cells are clustered together, agglutination, this means the immunoglobulin did meet the antigen and the cells are attached to one another like this. So if I have agglutination reaction with both anti-A and anti-B, so this means what? I am a blood group of which type? If the reaction takes place with anti-A and anti-B, this means I have both antigen A and antigen B on the surface of my cell, and I'm a blood group type AB. If you notice on here, anti-A, I've got a reaction. Anti-B, no reaction. So this means what? This means that my red blood cells only carry the antigen A, because with antigen A, I've got a reaction with anti-A. So if I have antigen A, you're gonna get a reaction with anti-A. So this means that on the red blood cells, you have antigen A, and you didn't get a reaction with anti-B. This means you don't have antigen B, so your blood type is blood type A. Looking on here, reaction was anti-B only, no reaction was anti-A. So this means I'm a blood group type B. I don't see any agglutination reaction neither with anti-A or anti-B. So this means I have red blood cells that don't express neither antigen A or antigen B on their surface. This will make the blood I'm testing here is a blood group type. RH, we have 45 different RH antigens. This includes C, D, and E. RH positive means I am presenting antigen D on the surface of my cells. Anti-RH antibody will form if an RH negative individual receives RH positive blood. Second exposure to RH blood will result in a typical transfusion reaction. Remember, it can pass unnoticed on the first exposure. Only I will get a transfusion reaction and a second exposure. Again, when would I have a transfusion reaction? If the donor's cells are attacked by the recipient's plasma antibodies. This will cause the rupture and the release of the hemoglobin from the red blood cells. Hemoglobin, when released freely in the bloodstream, gonna cause a blockage of the kidney tubules, and this will result in a diminished filtration rate, causing renal failure. All right, so for extra credit points, 4 or 5 extra credit points towards your final course grade. Those are 5 points, not 5%. 5 points that will be added to whatever you're gonna have out of 1,000 points towards this course for blood donation. So if you completed a blood donation at this address or anywhere else, just ask them to get a proof that you have donated blood, and you're gonna be submitting this with your in-class activities at the end of the semester. All right, so at the end of the semester, if you want to submit a blood donation receipt, you can get 5 extra credit points that will be added towards your final course grade. Any questions? Any questions? No, the receipt will be added anywhere in your course activity. Most likely people will add it to the very first page of the course activity document. Right, for today's in-class activity, we didn't complete any in-class activity for today yet. Questions? All right, we can have a 10 minutes break. We come back, discuss more about the blood and immunity. We'll see you in 10.